And good afternoon. Welcome to Tuesday Topics, the second part of ICP for you and me, part 2. So again, it doesn't matter if you attended part 1, you'll still get something, I hope, very meaningful from part 2. So really important to remember, this is a quick review. When we talk about intracranial pressure monitoring, we talk about the intracranial compartment. It's important to remember that the skull is rigid, that the dura is rigid. So this is a non-compliant compartment. So any increase in volume, and the volume we talk about here is brain volume, blood volume, and cerebral spinal fluid volume. So any increase in the occupation between spinal fluid, blood, and brain, this is controlled blood, this is controlled cerebral spinal fluid, this is the regular brain. Really incredibly important to remember that when we talk about an increase in volume, we're talking about free water, we're talking about engorged chambers holding cerebral spinal fluid, we're talking about an increase in our brain volume, or we're talking about an increase in free blood. You can also have an increase in the controlled blood in the blood vessel, but really important to remember these three occupants. So 80% occupied by brain, 10% by blood, 10% by cerebral spinal fluid. So really, really important for us to remember that our goals when we're trying to control the occupation in the brain, we actually decrease cerebral spinal fluid by diverting it out of the body and collecting it externally. We can vasoconstrict to decrease cerebral blood volumes. We can remove a mass lesion, or we can mobilize free water. So those are really conceptually the way that we're going to deal when there is too much volume in the space. Too much volume in the space gives you an increase in pressure. Because remember the basic concepts, pressure is compliance and volume. So when you are non-compliant, even a CC increase in volume inside the cranial vault will increase that pressure. So we think about those global principles and our methodologies for managing increased ICP. What we want to do is reduce intracranial pressure and improve perfusion. So I want to make sure we all appreciate whenever we're dealing with a patient who has increased intracranial pressure, we are doing two things. We want to decrease the intracranial pressure, and we want to improve the blood flow. Now, here's the problem. When I increase the blood flow, cerebral perfusion, when I increase the blood flow, that's going to cause an increase in the pressure. So I have to actually significantly accommodate for the desire to increase blood flow by significantly reducing the ICP. And then by accepting that as I increase the blood flow, the ICP may come back up again. Now, there's some very basic global measures. First and foremost, sedation, hypothermia, pentabarb coma, decompressive craniectomy, and steroids. These are all part and parcel of the therapeutic intervention that we can apply when we have patients who have increased intracranial pressure. So basically, the ENLS, the Emergency Neurologic Life Support, actually says we should always think about any kind of issue with increased intracranial pressure as a brain code. And there's a lot of different reasons that we have an increase in intracranial pressure. So this is not the final list, but it is a significant list. This is extra axial. That means that there is free blood or increased volume or increased mass that is taking space, that is causing an increase in intracranial pressure. And those can be related to basic focal brain processes or diffuse brain processes, all of which are going to increase the intracranial pressure. So we can think about all these things and say, well,
I will. That would be awesome. I will. Wasn't she here at one point before? Yep.
Okay. Anyone who's joined, please make sure you've muted yourself. I think I got you. Okay. So really, really important that even though you might not work in a neuro unit, you can have a patient who has a subarachnoid hemorrhage. That's going to cause some diffuse changes that cause increase in intracranial pressure. Lots of us take care of patients who have brain abscess, that have non-infectious neuroinflammatory disorders. For many of us, strokes, tumors, and hemorrhages primarily go to a neuro unit, and TBI primarily goes to the trauma unit. But there are many things that happen that increase intracranial pressure, which is why we really need to appreciate it. So I want to divide those pathologic causes to both to basic to injury of the actual functional brain, which is concussion and contusion, what we call also the coup, contra coup. So you hit at such force, the brain moves inside the skull, hits the front and reverberates back and hits the posterior surface. That's a very significant in the TBI population. And then if you look at this, it makes a lot of sense. Subdural, epidural, subarachnoid, hydrocephalus, tumor, edema, and abscess, those are all occupying space. Well, 100% of the space was already occupied. So when we have space occupying lesions, that means intracranial pressure is going to go up because there's no room. That's why one of the first things that we talk about and think about may not be the first thing we do, but it's one of the first things we talk about and think about is making room for the swollen brain by taking off the cranium or a piece of the cranium to allow for that enlarged brain, that engorged brain to swell through the hole rather than to compress downwards in a herniation syndrome. So we just take a quick look at a couple of different CTs, and you can see here that you've got a patient with a epidural hematoma, this patient who has a mass lesion, this patient who has acute swelling, and now compression of the fluid-filled chambers, the ventricles. So lots of different reasons that tell us that we have a patient who's at risk, a patient who's at risk for herniation, who has space-occupying lesions, who also has edema formation, and who is shifting the brain from side to side or from above to below. So really, really important, again, for us to remember when we talk about intracranial pressure monitoring, that we always remember that what we're looking at is a compliance and a volume curve. And what we measure is ICP. And as you increase the volume or you decrease the compliance, what you're going to see is that significant increase in ICP. Now, in today's world, used to be that we talked about ICP was elevated if it was greater than 20. But in the new ENLS guidelines, elevated ICP is greater than 22 and is sustained there for greater than 5 minutes. And that's really important because what that is telling us is we've got a lot of volume occupation in a low compliance surface when our ICP is greater than 22. This is dangerous. So whenever you see that sustained ICP for greater than 5 minutes, you need to be concerned. Now, the other aspect that we talk about, and we're going to look at a little bit more later, is cerebral perfusion pressure, which is driving pressure, MAP, minus resistance pressure, which is ICP. MAP minus ICP equals CPP. And we would always like for cerebral perfusion pressure, CPP, to be 60 or greater. So what does that mean? It means you walk into the room and you have a patient with an ICP of 30. Don't just drive their MAP up. You've got to get the ICP down and mildly elevate the MAP. You're going to do those two things always together. It's always synergistic. Bring down the resistance, bring up the blood flow so you can achieve a CPP. But those two are always done together. They're not done in isolation. Now, you and I will have an elevated ICP when we cough, when we sneeze, when we bear down to have a baby, when we bear down to have a bowel movement, our ICP goes up. But we have lots of autoregulation in place and it comes right back down, usually within 10 to 20 seconds. So the issue of having an elevated ICP by itself is not as worrisome as an elevated ICP that is sustained. So again, when you're looking at your patient and you've turned them and ICP goes up, you wait to see how long it is before it comes back down, right? If it doesn't come back down in 5 minutes, this is an emergency. If the ICP goes up, but it comes back down in about 15 to 20 seconds, you're going to note that the ICP elevated in relationship to turning or to suctioning or whatever it was you were doing, all of which you should expect to cause an increase in the ICP, which is why lots of times the discussion, somebody with risk factors for ICP and herniation, the discussion is sedate before you do therapeutic intervention so that you don't have these big spikes in their ICP. Regardless, depending on your protocol, if that's not what you're doing, what you always want to be sure of is that when you see ICP elevate, you put a timer on it and you're looking at how long it stays elevated. So by those new guidelines, that's the AANS, American Association of Neurosurgeons, the AANN, the American Association of Neurosurgical Nurses, and the ENLS Committee, Emergency Neurologic Life Support for the Brain Code. They all agree 22 or above, sustained for 5 minutes. This is an emergency. So we need to be aware of that because we're at the bedside monitoring those patients. Now, increased ICP actually can put us at risk, of course, for herniation. And there are a lot of different types of herniation. Not necessary that we understand every single, I mean, it's wonderful to understand all the signs and symptoms, but to appreciate that herniation is going to occur, and it's going to occur side to side, it's going to occur up, it's going to occur down, and it's going to occur down into the spinal column. And so any herniation, which basically means that your brain volume has moved from one space into another, is actually a prodrome for non-survivability. Okay, so remember, lots of things make your ICP go up: coughing, sneezing, lifting, bending, bearing down, stress, blood pressure, getting upset. These are all things that make ICP go up. And primary factors that influence that elevation ICP are really related to your blood pressure. So remember, this is such a sticky wicket. We don't want your blood pressure up too high, but we need to achieve a CPP. That's why you do those two things synergistically. You don't just put vasopressors on a person with a subarachnoid hemorrhage or a traumatic brain injury to drive their blood pressure up without reducing the ICP. So we're really going to think about those relationships. We're also going to think about intrathoracic and intra-abdominal pressures. So when I put you on a ventilator, I'm on positive pressure, I'm on a lot of PEEP, that's going to actually communicate by compressing the veins, and the outflow of blood and cerebral spinal fluid ultimately is through venous drainage. So when I put you on a PEEP of 10 or 12, I'm going to really significantly limit venous outflow drainage. That's going to make your ICP go up. Same thing with intra-abdominal. Let's just talk about intra-abdominal hypertension, not abdominal compartment syndrome. Just remember, with your sick patients who've got aggressive fluid resuscitation, they probably have had a lot of fluid creep. They're leaking fluid from the vessels into the interstitium. And you're knowing that because their urine output is going down. And you're thinking about, well, how do I make them make more urine? Do I give more fluid? You give more fluid. Now they have no urine output. And we take a look at the abdomen, and there's a lot of edema, not free water, but edema in the abdomen. That's compressing the bladder. As soon as you see that the bladder is being compressed by the free water in the abdomen, you need to remember that's influencing your ICP, and it's profoundly influencing ICP. So we have to be the thing about being a critical care nurse is you can't get too focused on one thing. You've got to look at everything. You've got to look at how everything interacts. Now, obviously, if the patient is hyperthermic, that's going to increase their ICP. If they have pain or agitation, that's going to increase their ICP. We also know that if you have metabolic acidosis or respiratory acidosis, but in particular, respiratory acidosis, so high CO2, high metabolic acid, which is hydrogen, which you're evaluating because the bicarb or the base is low, what you're going to expect to see is that the patient is going to have cerebral vasodilation. Now, once they dilate their vessels inside the cranial vault, that's going to increase their brain volume, and that's going to cause an increase in ICP. So you might remember 20 or 30 years ago, if any of you were around at that time, one of the first things we did for somebody who had elevated ICP is we would hyperventilate and blow off their CO2 down to about 20. Well, the problem with that is when you were blowing off all that CO2, they would vasoconstrict, and now they didn't have good blood flow delivering oxygen. So now we're much more cautious. We typically actually like to keep patients with a PaCO2 of around 32. It's not aggressive hyperventilation, but it's assumably that fine line of maintenance of the blood vessel and achieving enough blood flow with oxygen without over aggressively vasoconstricting or over negligently allowing vasodilation. So that's a really important concept for us when we're talking about what we're doing with and for our patients. Okay. And of course, hypoxia. So limitation in oxygen delivery to the brain. The brain continues to metabolize no matter what. So here's the thing about the brain that's so incredibly important. The cerebral cells utilize glucose without the benefit of insulin. So every time you have excess glucose, the cerebral cells are utilizing it. And if you don't have enough oxygen to support the metabolism of the glucose, you're going to produce all these very significant secondary products that are radicalized products. And you know what radicals do? They destroy everything. Well, oxyradicals and these other radicals that are produced in hypoxia in the brain cause cerebral destruction. So we are paying a particular attention. We don't want to see anything happen to any of your other organs that's going to increase the intracranial pressure, either by limiting venous outflow or by delivering too much cerebral blood volume, because of course, that's going to increase your intracranial pressure. And we have a lot of responsibility here. Okay, so this is a very busy slide, but it's actually quite important, okay? That what we talk about with ICP is first stage, which is you yourself as the individual with increased ICP, you are actually going to compensate for this by shifting cerebral spinal fluid. So I've got free water, edema, I've got free blood, I have a brain mass, or I have blood volume issues, or maybe I have issues in reabsorbing cerebral spinal fluid. The compensatory phase is within a certain window of opportunity, I can shift off cerebral spinal fluid to make room for that increase in space. It's a small compensatory window, okay? And that compensatory window is known as autoregulation. But stage 2, you start to decompensate and your ICP goes up. But now, because you can no longer shift off cerebral spinal fluid, what's now going to happen is you're going to start to compress your arteries. Once your pressure is increased and you are decompensating, you're going to compress your arteries. That means that your blood flow has been reduced. So now, distal to that, you've got hypoxic brain. Okay, well, then that leads to a very significant phase. Okay, that's really going to be the much more harmful phase because you've lost all compensation and everything that happens. So we're outside of you giving you norepinephrine and epinephrine and vasopressin. Your blood flow is increasing, but there is no room. You've shunted off all your cerebral spinal fluid and you've compressed your arteries. So now the distal surfaces of the brain are not receiving oxygen. They're breaking apart. You now have brain swelling and ultimately brain swelling. So that's really in that decompensatory phase, that brain swelling leads to herniation. So I want to make sure you appreciate what I've said here. You are all about monitoring that ICP. You are all about monitoring the MAP and being aware of CPP. But I want you to remember that every issue in increased ICP is always about blood flow. The higher the ICP, the more limitation you have on the blood flow. And as the patient actually goes from compensation to decompensation, what's going to happen in that decompensatory phase is, of course, severe, profound brain swelling, herniation, and death. So this is my simple cartoon. My simple cartoon just reminds you that ICP is about compliance and the volume, and it's a pressure measure. Talks about resistance to blood flow through the cranial vault. And MAP is the driving pressure. So this is a very simple dynamic. It says MAP minus ICP yields CPP, cerebral perfusion pressure. Now, really, really important to remember that if you don't remember anything else that I say, The single most important thing is when I have a patient with elevated ICP, you've got seconds to try to restore cerebral blood flow. But you cannot do that only by increasing MAP. You must also reduce the ICP, and those two things go together. So if I'm starting to titrate up on Levophed, I also have to think about what is it I can do? Can I make the room cool, dark, and quiet? Can I elevate the head? Can I increase sedation? Can I give a bolus of sedation? Do I need to call my doctor? Do I need to put the patient in a coma? Do they need the cranium to be open? I can't allow a patient to have a CPP of less than 60 and or an ICP of greater than 22 for any length of time. So I'm actually juggling both sides of that coin, decreasing ICP, increasing MAP, trying to restore a regulated CPP, but I have to have a low ICP for that to happen. I can't just make it up because I got an MAP on the monitor. I've got to get that ICP down. Okay, so I'm not going to talk too much about this, although it's probably quite important. If you work in a neuro unit, which I don't know anybody does who's on this call, we do use a brain parenchymal oximeter. It's called brain tissue oxygenation, also known as the Lycox catheter. And we drill that catheter down to the brain parenchyma, and it measures the oxygen at that surface area. Now, it's not regional, it's local, but it tells us really great information about whether or not we have appropriate oxygenation at the brain. And when you're increasing your ICP, what you're going to expect to see is that brain tissue oxygen is going to go down, and that's dastardly, but it's another tool in our armamentarium. So if I see ICP is up, I'm trying to get MAP up, and brain tissue oxygen is falling, I'm doing the wrong thing. I really have to try to get that ICP down. And actually, I think brain tissue oxygen monitoring is one of the best underscoring theoretic substructures to drive the need for decompressive crani. So why is this so important? I think it makes perfect sense, right? We want to maintain that cerebral perfusion pressure. It's the main focus for us when we talk about cerebral injuries, because it's what actually helps us to evaluate the patient's blood flow in the cranial vault. Now, we really want ICP, but let's say you work in an area where you don't have ICP, but you got a CVP. So you're going to take MAP minus CVP. It's indirect, it's primitive, but it will actually present very similarly to MAP minus ICP. So I'm working in a trauma unit. I think the patient had traumatic brain injury, but I'm not monitoring ICP. I am monitoring CVP. CVP is 22, and my MAP, I'm thinking is pretty okay. My MAP is 65, CVP is 22, MAP is 65. The MAP is very successful, but the CVP is 22. So if I'm using that CVP to reflect what's occurring in the cranial vault, I'm going to take my MAP 65 minus my CVP 22, and that gives me a CPP of 43. CPP of 60 is what you're trying to achieve. So you got to get that resistance down. Now, your CVP might be 22 because you've got a lot of PEEP. So maybe we need to reduce PEEP by 1. Maybe we need to promote some pulmonary vasodilation. As we support pulmonary dilation, the right heart will mobilize its blood flow better, and the CVP will start to drop. So you got to really think about these correlates when you're talking about ICP monitoring and what you can do. So here at Grady, our neurologists, our neurocritical care doctors who are intensivists are going to say, I like to see a much higher CPP. 60 is acceptable, but it's a really low level. I'd like to see it higher. Now, 60 is what we consider acceptable in brain injury, but we want to make sure that we're trying to achieve a little bit higher level. So here's the problem. A CPP less than 30, irreversible ischemia and damage, patient can never recover. CPP less than 50 typically indicates that you have very significant hypoperfusion and some brain ischemia. So you might be thinking, well, a higher CPP must be better. Well, no, that's not true. Remember, we'd like to maintain CPP between 60 and 100. And if that CPP is greater than 150. And remember, a lot of these patients will have significant hypertension. Their MAPs will be really high. And then 20 minutes later, their ICP is high because they've had some ischemia that occurs. Greater than 150 disrupts that blood-brain barrier. So I want to make sure, for me, when I was younger and learning, I was like, the blood-brain barrier, what the heck is that? Really, all it is the wall of your capillaries. And embedded in the wall of your capillaries is something called the glycocalyx. And the glycocalyx is basically like a regulation police officer. It only allows certain things to pass from the blood vessel into the interstitium of the brain or any other organ. Okay, but when you have a high pressure, when you have high hydrostasis, or when you have a high pressure, you disrupt that glycocalyx. So now everything can pass across that barrier. That's what the blood-brain barrier is. It is this basic presentation that separates the cerebral cells from the blood in your vessels. And that causes significant alteration because it can cause a lot of brain swelling and it can lead to herniation syndrome. Okay, so, oh gosh, in the face of everything that's going on in this world today, I'm just going to share with you, I worked with Dr. Vernon Henderson at AMC on a project of comparative analysis of brain tissue oxygen to intraventricular ICP. So the brain tissue oxygen probe was placed on the non-injured side of the brain, and the ventriculostomy was placed on the injured side of the brain into the ventricle, measuring the ICP and draining cerebral spinal fluid. So you can see this is an individual who suffered a very significant injury. He was in a motor vehicle collision. He had a can of gas in the back seat and his car exploded. So he also had very severe burns, but he had a profound brain injury because he was thrown at great force from the car when the car exploded. When we dropped his brain tissue oxygen monitor, normal brain tissue oxygen should be 15 or greater. His brain tissue oxygen on the uninjured side was actually around 10. But as his ICP went up and the brain shifted, the brain tissue oxygen dropped down to about 3. You can see he had a PA catheter, a lot of other things that occurred. And it was really, really profoundly informative because, by the way, he had fluid-induced ARDS and his PEEP was on 17. Now, because I was doing a trial and a study, we did 7 patients. And what we found was that it so importantly impacted our practice, we couldn't ethically continue on the trial. And it was just a self-generated trial. I just received equipment support from the vendor, and Dr. Henderson was gracious enough to be my co-PI. But by the time we got to 7 patients, we said, oh my God, monitoring just CSF is completely inadequate because the brain tissue oxygen also told us about when there was significant limitation to the delivery of oxygen to the tissue, because it's looking at the interstitial oxygen as oxygen goes from blood to interstitium to cell. And also what it told us about was functional anemia. And so we actually were using a lot of red cell replacement in these patients, more than we would have done normally, because that was one of the best ways we could treat their brain tissue oxygen. You can't believe that this patient, he walked out of AMC. He walked out. Now, he wasn't completely functional. He needed lots and lots of support, but he survived a really aggressive head injury. I mean, he had a GCS of 3. And that when we first saw him, his GCS was 3. It was a really significant injury. And you can see he looks pretty bad. This is almost like 4 hours after he's admitted to the trauma unit. And that's why he has blood coming out of his ear. He's kind of a mess. And I'm sorry. It's just a very great picture to kind of talk about why this relies on you, why it's so important that you're paying attention to these details. Now, all of us can't monitor brain tissue oxygen. None of us are putting an intraventric and a brain tissue oxy monitor on the other side, unless we're doing research. But we can monitor vital signs. We can monitor neuroassessments, and we should be doing that every day in patients who are at risk. Now, let's think about the patients we know are at risk. People who have subarachnoid hemorrhage, people who have intracerebral hemorrhage, people who have epidural bleeds, subdural bleeds, patients with traumatic brain injury, patients with meningitis, lots of patients that are neuro risks. But the other patient I want you to remember is the patient who has gained 10 to 15 kilograms in your ICU from fluid overload. Fluid overload all by itself can cause a disruption in that blood-brain barrier and can cause intracerebral edema. So we really have to be thinking about this, no matter where you work. Emergency, MICU, SICU, trauma, neuro, you need to be thinking about this because it's a big constellation that comes back to aggressive fluid resuscitation without a target. And that's so important to us in terms of how we look at our patients. Now, two things that we can do that are really important is we resuscitate to a target. From my point of view, that target should always be stroke volume. However it is that you're doing that, you do it with a Lidco, a Pico, a Starling, a flow track, a Clear. I don't care what tool you use, but having a target for resuscitation can help limit the fluid creep into the interstitium of all of your surfaces. But the one we're most worried about is the one we can't see, which is intracranial, right? And most of our patients who do have some intracranial edema do not have ICP monitoring because they didn't have a head injury. Nobody wants to put a bolt in someone's head or put an intraventricular catheter through the brain parenchyma into the ventricle. These are not without risk. So no one wants to do that unless absolutely necessary. So one of the most important things that you were going to think about is CVP and MAP. MAP up and CVP down. And CVP down is not just about withholding fluid, it's just about improving the compliance of the right ventricle. Okay. If my patient has increasing ICP, I'm going to think a lot about the presentation. And there's a lot of things, and there are a lot of subtle things and particular things to different surface areas. We're just going to say what the general issues are. Of course, the most important one is a change in level of consciousness and a decrease in motor function. These are the most common, but also an increase in restless activity. Increasing restlessness, typically in a person, particularly who's at risk, indicates to you that the ICP is increasing. Now, they may have some other deficits and some other problems, sensory deficits, visual changes or visual deficits, seizures, papillary changes, pupillary changes. But really, the first four are probably the ones that we look at the most. Lots of our patients can't say, hey, I've got the worst headache I've ever had in my life because they're intubated on a ventilator. Obviously, if you're seeing seizures, remember that seizures occur in the face of brain dysfunction because you don't have balance of your ions at the cellular level because you've lost your oxygen-controlled pump that actually mobilizes sodium and potassium effectively. So whenever your brain is hypoxic, you're at risk for seizures and very commonly do so. So we're going to think about elevated blood pressure with no obvious cause, like you're just laying in the bed, you're not in pain, you've got sedation on board, and all of a sudden the blood pressure goes up. Now people say, oh, that's neurostorming. Well, okay, but if your blood pressure goes up with no obvious cause, your ICP is elevated. If your ICP is elevated, you're compressing the arterial blood flow in the cranial vault. It's not okay. So we're going to do everything we can to control it. It's pretty hard to do. When it's a neurologically induced hypertension, it's hard to do. But we want to look at elevated blood pressure with no obvious cause. We also want to look at the trend of rising systolic pressure and what we call a widening pulse pressure. That's systole minus diastole. So what actually happens is your diastolic pressure tends to stay the same or start to go down. The same time your systolic pressure is going up, that gives you a wide pulse pressure. Wide pulse pressure only occurs if you have an effective stroke volume. But what that means is now I've got a lot of blood flow going into the cranial vault, a lot of cerebral blood volume in the cranial vault, causing the intracranial pressure to go up. Okay, so that's really important. And then ultimately, you may see some significant bradycardia. So you have a lot of parasympathetic stimulation as well as sympathetic stimulation. That's one of the reasons that you will often see bradycardia. Now, typically we call this Cushing's response, right? that Cushing's triad. Hypertension with widening pulse pressure, bradycardia, and then the last one, which is irregular breathing. So not necessarily Cheyne-Stokes. There's lots of different Biot's breathing, a lot of different breathing patterns, but normally it's short, long, short, long, short, long, followed by cessation, or short, long cessation, or long, short cessation. It's just a respiratory irregularity. So if your respiratory alarm is going off, or you're looking at the respiratory waveform and you're seeing irregularities in a person who's at risk, think about the possibility that this is one of the later signs, right? Pulse pressure widens, bradycardia in irregular respirations, named for Dr. Cushing, the same guy who named Cushing's syndrome in the adrenal gland, same doc. You love to look at the brain and the endocrine function. And just remember that that complex approach here, hypertension with widening pulse pressure, bradycardia, irregular respirations, that's a really late sign. Your patient is already herniating. So our goal is to monitor you faithfully before that period of time. Now, once we start to see herniation, we're going to think about what we've got to do aggressively. And I mean right now, not when docs are done with rounds. I don't want to disturb the doctor. It's the middle of the night. Forget all that. This is an emergency, right? You've got these things that are really important that we see as a prodrome of herniation: decreased mental status, changes in the respiratory rate and the respiratory depth and pattern, that they may have a dilated pupil and a non-reactive pupil, that there could be hemiparesis, there could be some posturing either. So when we think about our posturing, we're always going to remember you're pointing to the area up to the cerebral or down to the cerebellum. So always remind yourself about decerebrate and decorticate posturing. Become familiar with that. Yes, it can be unilateral. Yes, it can come and go. I hear people say, well, I can't come and go. Yes, it can. Yes, and it can be different on the upper extremity from the lower extremity. And that's why you have to look at all the extremities and really evaluate that patient. If you don't recognize these things and initiate a response, it's likely going to be fatal, and it may be fatal anyway. So what we're going to do once we see these signs, and whether we're monitoring ICP or not, but hopefully we are, and we're making some assumption about herniation, I want to make sure you appreciate. So this is basically the herniation picture. I meant to put it on the herniation page, but that's okay. Here it is here. Okay, so remember I said you can herniate in an upwards fashion, compress your ventricles. You can herniate down through the falx cerebri, and that's what's separating the cerebri from the cerebral hemispheres from the cerebellum. You can herniate down through the foramen magnum down onto your spinal column. So once you've herniated, there's really nothing we can do. Once you've herniated, that's it. So what I want to do is I want to know that you are initiating herniation. You have a high ICP, you're initiating herniation. And there are basically 4 things that we can do here, okay? One of them we don't like to do, okay? First and foremost, hypertonic saline. Secondarily, mannitol, 1 to 2 grams per kilogram. Hyperventilate, and here in this instance, we might consider hyperventilation, probably not to 25, maybe to 28, and that's only in an emergency. Otherwise, it's to 32. And very rapidly, we're going to consider taking off a bone. So here's your injury, here's your swelling. I'm going to take that bone off and allow space and room for you actually to basically herniate upwards, not compressing your cerebral blood vessels, not compressing the brainy function parts. Okay. So that brings me back to the waveforms of ICP. So ICP, oftentimes on your monitor, you have it in a large scale and it just looks like a little wiggle. You need to put it in the smallest possible scale so that you can see the differential criteria of the ICP. P1, which represents the increase in pressure on systolic ejection of blood, so an increased blood flow into the cranial vault. P2, as blood perfuses the cranial vault. This is the best measure of cerebral compliance. And P3 is actually often called the dicrotic notch. P3 is related to the closure of the aortic valve. Okay, so there are 2 things we're not really, most of us don't care much about P3 or that notch. We care about P1 and P2. So oftentimes you can see here In an early compensation, you'll see in the intracranial pressure that P1 goes up, P2 and P3, it doesn't say that, but this is P2 and P3. P1 goes up and is much greater than P2 and P3. Okay, so this is a really big P1. Your ICP is actually being monitored by your monitor as the average between the peak and the trough, but your real pressure is the peak of P1. So your monitor is not going to call that the ICP, but you as the bedside nurse are looking at the waveform. You're saying, hey, P1 is 28. The average between P1 and the trough, which is like 8. So 28 plus 8, 36 divided in half, that's about 18. Well, that kind of falls under your guideline of being concerned, but that P1 is really big. So when P1 is really big, we're going to always think about that and how important that is. And then as you have lost some of your compensation, you are really non-compliant. You are not just going to see an elevation P1. Now you're going to see an elevation P2, which is a compliance measure. So whether you know the names of the waves or you can even explain them, there's just 3 fluctuations in your ICP, P1, P2, P3. P1, when your heart ejects volume during systole and the systolic impetus of volume that goes up into the cranial vault, that elicits P1. P2 is the track as the blood flows through the cranial vault, no longer in systole, really in diastole, and that limb tells us about compliance. So P1 tells us about brain response to systolic ejection, and P2 tells us about compliance. P3 doesn't have a lot of meaning, but of course we always want to know what's there. This is incredibly important. If you have the opportunity to monitor ICP, you want to see those waveforms. Okay. There's that ICP and herniation. Okay, so when we're looking at our patients with increased ICP, early and late being herniation, right? Early patients, if they're able to tell you, they complain of a headache, they seem very kind of agitated, they're irritable, they may have vomiting, they have usually very severe photophobia. Their eyes are hurting, their eyes are closed. You ask them to open their eyes and they're like, no, because it hurts so much when they open their eyes. They also oftentimes have double vision, and they may have nystagmus, right? So that's, remember what nystagmus is, it's the deviation of the eye to the side and then fasciculation. They may have lethargy and they may have seizures. Later, you're actually herniating. So later, your GCS drops aggressively. Remember, when GCS drops 2 points in a head injured patient, you got to get to the CT scanner. You don't have time to wait. You got to go to the CT scanner. And then you're going to see changes in the ipsilateral pupil. So on the side where herniation is starting to begin, you're going to get that dilated pupil, and the other side may be somewhat responsive or may have very low responsiveness. And now they have newer worsening hemiparesis. Really, really important to remember that by the time you get to Cushing's triad, an increase in systolic pressure, a widened pulse pressure, bradycardia, and irregular respirations, you're already herniating. So we have a lot of different treatment that we can induce for our patients. We talk about it as stage treatment. You can see in stage 1, these are basic kinds of things. We're going to monitor CVP, we're going to monitor ICP, we're going to monitor arterial pressure. All of that should be invasive, right? And we're going to give sedation and analgesia to a RASS usually of -3 to -4. You may even go to -5. With sedation, you're going to be aggressive with analgesia. You may even use a paralytic. You might use phenobarb coma, or pentabarb coma. That's going to be a little bit later, typically. But one of the things you can do is make sure that neck is straight and make sure the head of the bed is up, because you want to facilitate drainage. You want to facilitate venous outflow. ICP greater than 25, we're going to move to stage 2. Okay. At stage 2, we're going to put a catheter in your ventricle to drain cerebral spinal fluid. We're going to mannitol, hypertonic saline, probably some loop diuretics to make you urinate in conjunction with the mannitol. Might give you steroids to reduce the brain inflammation. We are most likely going to make you cooler. Now, even if we don't make you cool, because recent data is saying that making patients 34, 35, 36 degrees can be non-beneficial in a head injury. And I'm just going to share with you, just in terms of hypothermia, 36 degrees in hypothermia, 36 degrees is deeply embedded in the seizure and shivering threshold. So that means you're better off to be 33 than you are to be 36. You're better off to be 37.5 than you are to be 36. So really, the idea is, do I want to make the patient really quite cold, like 33, 34, or do I just want to maintain normal thermia? And that's a decision your neuro team comes up with. Our neuro team here used to be very aggressive with hypothermia. We are no longer aggressive with hypothermia. So very, very, very important when we're thinking about this relationship and having some clear understanding about this. We're not going to give barbiturates in stage 2. We're not going to give barbiturates until we see that you are really, really profoundly refractory. Now, this is a collaborator trial. It's really what's underlying what we do today. So here you are in stage 2. And then if your ICP is maintained above 25 for one or more hours, then we're going to look at decompressive craniotomy. We also would look at a pentabarb coma. So that's really how people kind of put this all together. So let's take a quick look at some cases. They're pretty simple. These are not my cases. They are from the ENLS board, and they're really very simple. So 64-year-old man in an auto versus pedestrian accident. His GCS is 7 in the ED, has no focal neurologic deficit, temperature 35.7, heart rate 95, blood pressure 115/62, and his SAT is 85%. So he's intubated because of his GCS, because of his hypoxia. We put him on 100% FiO2, and he's on about 11 or 12 of PEEP. And when we see the CT, we see that he has very significant contusions, and he has some subdural blood. So very significant contusions, and they're bilateral, bifrontal contusions. We already have compression of his ventricle, and we may have just a little dural shift, okay? So based on this, an EVD, an extra ventricular drain, but really what I'm going to call it is a ventriculostomy. A ventriculostomy is placed. So we place that ventriculostomy, and his what we call the opening ICP is 29, and it's sustained at 29. So that means, this is an emergency greater than 29. So just remember the kinds of ICP monitoring that you can do. And also remember, as soon as you've opened the brain, you're looking at the ICP, just remember the normal ICP. And then over here, when you're looking at somebody who's lost compliance, their P2 goes up. You almost don't have a P3. Here's your P1, which is elevated, and your P2, which is elevated. And oftentimes P2 greater than P1 is a prodrome that the patient's not going to survive. So P2 greater than P1, you have very poor compliance, and the probability is you're going to herniate. So when you're looking at ICPs on your patients, if you're lucky enough to see them, you really have to pay attention to that waveform, not just the digital readout, but if P2 is equal to or higher than P1, that is prodrome for herniation. Now, you may not be able to do anything to stop it, but you can prepare the family. You can try to assure that people are available, that they can spend a few minutes with their loved one. Honestly, from my point of view, one of the things to always think about is to recognize that a lot of times what we do is try to resuscitate patients. But once you get to the point of herniation, there's really not much choice or chance for resuscitation. So our next choice is to promote a good death. Peaceful, with family at bedside, feeling no pain, feeling no anxiety. These are things that we can advocate for, and most of the time we can implement. So it is really, really important to think about this. I'm going to just share with you, my son was with a woman for 13 years. So they basically were married. They were not married. And her mother was, she was like doing something at church, and she just got this terrible headache. She went home. The headache didn't get any better. You know what's coming, right? So the next morning she drives herself to the hospital. And as soon as she arrives in the ED, she drops her GCS from 14 down to 4. And they do her first head CT. She has a huge aneurysmic bleed, a huge intracerebral hematoma. She's already shifted. So they do everything they can for stage 1 and stage 2, but she's already herniated. So my son calls me they get permission for me to look at the CT. I'm not a neuro expert, but I said, we need a second opinion, and I'm going to get one of the best second opinions in the world. It's not me. It was Jonathan Radcliffe. God bless him. He's our head of neurointensive care. He and the clinical manager for the clinical director for neuroscience took a look at that, and they said, they sent me an email. We're going to call you later. Well, I knew what that meant. We're going to call you in a few minutes. And they called me and they said, are you someplace where you're alone? And of course, you know, I work in healthcare. I know what that means. And they said, we are so sorry. She is already herniated and there is nothing that can be done for her. Nothing. Well, I really appreciated that they looked at that CT, and then I communicate back. It was a very, very hard communication with basically my daughter-in-law, her father, her brother, my son, to say there is nothing really that can be done. So this is now up to you. And I know how hard this is. They're in New York, I'm down here. I'm ready to jump on a plane. I'm happy to come, but also this is really about what you decide. And of course, their team is saying to them, this is not resolvable. I was so pleased with how their team handled it, because they said this, they didn't say, do you want us to do everything? Because families always want you to do everything. It wasn't resolvable. And they said it's not resolvable. So basically they maintained her, did what they could for about 2 days it was so shocking for the family. And after 2 days, they decided to withdraw care. It was really peaceful. Everyone was there. All the people from her church had come to visit. I mean, this was during COVID too. All the people from the church came to visit. And there was a lot of really excellent closure. Now, that doesn't mean it's easy, but a good death is not a terrible thing when we're talking about our patients. So we want to remind ourselves that we want to treat patients as soon as we recognize this. Once they've started to herniate, it's really too late. Okay, so we're going to get a non-contrast head CT. We're going to look at your blood gases. We want to minimize anything noxious. So that means, like, up in the neuro unit, your lights are off. That unit is so quiet. It's so calm. You go into trauma, you got somebody with a TBI in the trauma unit or in the trauma bay, lights are on, everybody's screaming and running around, and it's so chaotic and noisy. And okay, I love that too. But that's a really noxious stimuli for somebody with a head injury. And so one of the things to think about is, how do I keep the room cool, calm, and quiet? How do I keep the room dark? How do I communicate with the family to say your loved one definitely needs to know you're here, but not by you saying, open your eyes, open your eyes, open your eyes, wake up. You know what happened? I'm here. No, sit at the bedside, be gentle, stroke their hand, really quiet voices. And we really have to regulate that as bedside nurses. We really have to regulate that. We're going to add analgesia and sedation. That's by our doctor's order, but we're going to be very generous here with sedation and analgesia. We're going to ask for a good RASS score. Typically, RASS will be -3 to -4, may even be -5. You're going to use hyperosmolar or isotonic fluids. You're going to at least target normothermia. Now, a lot of these patients will elicit a fever, which will cause the ICP to go up and down and up and down and up and down. So frequently we'll put Arctic sun pads on them and maintain normothermia just for a continuous period of time to protect them from any fever that causes the ICP to go up. Again, we're going to always be sure that the neck is midline. We're going to elevate the head of bed to 30 degrees. We're going to avoid and correct hyponatremia, because as you become hyponatremic, which is easy to do with a head injury, that fluid is going to creep out into the interstitium. So we've got to really be vigilant about avoiding hyponatremia. We'd like to keep your sodium on the higher side, around 145. We're going to make it higher if we're using hypertonic saline, which is something that we can do. So those tier 1 measures, hyperosmolar therapy, temporary hyperventilation. Remember, ENLS is saying when you're at tier 1, you have an increased ICP, but you're not really herniating. Your ICP is elevated and sustained for a long period of time. You're going to hyperventilate down to a PaCO2 of around 30. You're going to drain cerebral spinal fluid, and you're going to consider decompression. Now, when we take that bone off and we take the dura off, that's embedded usually into the abdomen, or it's taken to a bone bake where it's kept viable. so that we can replace it once the swelling is gone. And that's also really important to explain. When you're talking to a family, we're going to take that bone off, but we're going to keep that bone alive. We're going to put it into the abdomen. We're going to keep it alive. Or we're going to take it to a bone bank where it's going to be kept alive, because that bone is really important to your loved one. And it may be a year before we put that bone back on. It might be soon, it might be long, but don't be worried. What we're doing is just giving space for the swollen brain to go, so that instead of going down to the spinal cord, which is herniation, it can swell upwards and we can still have good blood flow. It's a really wonderful thing. And, you know, we've been doing decompressive craniectomies for 25 years, but in the last 5 to 8 years, it's become a renewed methodology for management. So after several mannitol and hypertonic saline boluses, allowing his EVD to drain cerebral spinal fluid, his ICP lowers, but only to 27. He's still very elevated. He is mildly hyperventilated to a PCO2 at 33. So we did everything in that tier 1. Head of bed is elevated, neck is straight. We've given him hypertonic saline, we've given him mannitol, we mildly hyperventilate him, but his ICP is still 27. This is telling us this is refractory. So now we're going to increase to tier 2. We're going to start to give hyperosmolar therapy for sodium to be higher. Lower levels of hypertonic therapy is usually 150 to 160, but now I'm going to go up to 170, maybe 180. I'm going to optimize sedation and analgesia. Typically at this point, what you often will see is that Versed boluses and Versed drip starts to get added onto your propofol and your fentanyl. So now you're giving Versed boluses, you're titrating your drip. So you give 3 boluses, you titrate up. Sometimes patients are in a continuous Versed drip of 40, because we're trying to control ICP, right? But they're intubated, they're on a ventilator. We're not worried about that. We got to get that ICP down. So that's really, really important. And again, we're going to start really talking now about a decompressive surgery. Now, depending on your neurosurgeon, that's already been done. Or you have a neurosurgeon that says, I don't think the evidence is 100% in favor. There are some issues. There's a lot of long-term issues with decompressive cranies. So you've got somebody who's kind of a conservative surgeon, which is totally okay. They're like, I don't want to do it too early. I want to see if we can get the patient under control with medical management. So really, really, really important, right? You have to be able to do a brain image to do a surgical decompression. And if the patient doesn't meet criteria for surgery because of their condition, their age, their comorbidities, or if we cannot actually do brain imaging, we're not going to do a decompressive cranium. So very, very important to appreciate that. We're going to take that cranium off, going to give them room to swell, we're going to try to evacuate the mass lesion. If at all possible, evacuate the free blood, evacuate a tumor or a growth, if possible. So now patient gets placed on 3% sodium chloride. His serum sodium is 155. He's on propofol. ICPs remain 26. We repeat the head CT. It doesn't show any new hemorrhage, and neurosurgery says, I don't think you've really maximized, and I would agree. You have not maximized your medical therapy yet. He's not, and he has other issues. He does not meet surgical candidacy. Okay. So now remember what we talked about before. Now we got to go back and say, have we really done what we needed to do here? Do we need to hyperventilate him to a more significant level? Should I blow him off to 25? Should I titrate him to burst suppression on EEG? That means you're going to be at -5, and this is where you're adding in that Versed. And do I want to drop his temperature down to 32 or 33? Now, in general, we don't do that much anymore, but it is an option. It might be something that's part of your protocol, and that's okay. All right. So, by the way, the decision is, yeah, we're not going to decompress him, so we're going to move forward to higher level measures. We're going to put him in a coma with pentabarb. So a barbiturate coma with phenobarb or pentabarb, we're going to put you in a barbiturate coma. So that's what happens. He gets loaded with pentabarb. His EEG has burst suppressions, the 8 to 10 second range, which is significant decrease in the burst, the electrical burst and activity in the cerebral vault. And now his ICPs go down to 16. Woohoo! So We keep him on pentabarb, which seemed to do the trick. He didn't have to get a decompressive lap. He's on sedation analgesia. He got Versed. He got blown. We blew off his CO2. We made him hypothermic. None of that worked. But when we added pentabarb, it was pretty aggressive. That is a big gun, a really big gun. He was maintained on pentabarb for 48 hours and then is slowly weaned off. And during weaning, his ICP went up to about 15, but then it came back down to around 12 and stayed fairly well controlled. And ultimately, his EVD is removed. So always remember that ICP is just a symptom of swelling inside a closed vault. And the swelling in the closed vault compresses your cerebral vessels. So this is the reason we talk about things like brain tissue oxygenation. Something else that's probably familiar to many of you is transcranial Doppler, which actually looks at cerebral blood flow. That's intermittent, it's not necessarily continuous. And then the last, but probably one of the most interesting concepts for the future is cerebral microdialysis, which actually collects the cerebral spinal fluid and runs it through a dialyzer, looking at the presence of metabolic acid, hydrogen, looking at lactic acid, looking at glutamate, and other ions, which should not be in cerebral spinal fluid, to tell us about fluid creep, tissue hypoxia, and brain dysfunction. It's not a therapy. Microdialysis is not a therapy. Neither is brain tissue oxygen, neither is transcranial Doppler. Those are used to actually help us monitor what's really occurring so that we can derive a better program of intervention. Okay, so I'm not going to talk about pediatrics. Just want to remind you that good communication begins before patients reach the hospital. We always want to know what kind of injury mechanism a patient has had, if there's a good history, and very important, not just vital signs, but the patient's glucose. Anybody with a head injury, we need to know glucose right away. You cannot allow people to have a sustained hyperglycemia greater than 180 if they've had a head injury. That just propagates and expands their neurologic dysfunction. And then, of course, a neuroassessment and what interventions are being done. And then we think about, once we accept that patient, our continuous clinical neurologic exam every 1 hour to every 2 hours, treatments for increased intracranial pressure, whether we're monitoring it or not, and always anticipating what's going to come next if I have a patient who is refractory in responsiveness. It is a good idea to place an intraventricular or an intraparenchymal bolt to actually help us evaluate what the pressure is inside that cranial vault. Just like we evaluate arterial pressure, we need to evaluate intracranial pressure. It's nothing to be afraid of. Most of us, if we don't work in neuro, we're a little worried every time we get somebody who's got an ICP monitoring because we're uncertain about it. But it's pretty straightforward. Just remember, as ICP goes up, blood flow goes down. Increasing MAP does not necessarily increase the blood flow. If you increase MAP and you increase ICP, that does not increase blood flow. You always work synergistically together to increase MAP and to decrease ICP. And for ICP, remember, it's pretty straightforward. Head of neck, elevation in bed, minimize noxious stimuli, sedation, 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 analgesia, move sedation forward to bolus therapy with Versed, move forward from there to pentabarb coma. So these things have to happen quick while you still have brain function left before you actually herniate. Okay, so I'm going to end here. It's 5:01. Thank you so much for your attention. Thank you for joining today. I'm going to end the recording, but I'm going to be available for any questions. So thank you very much. Thank you everyone for joining. I appreciate it so much, and I'll see you next time.